Okay.
Thank you, Dr. Lambert. We do have two volunteers who have microphones, and we are able to take some questions. We do ask that anyone posing a question please identify themselves, their professional specialty or background as well, please.
Hi there. My name is Sheila Lee. I'm an infection control practitioner for social health. If we treat Lyme, one of the big concerns that I hear is antibiotic resistance. So are we seeing any antibiotic resistance with the treatment of Lyme disease and doxycycline?
Well, you can't grow the bacteria. So the only way to measure resistance is to be able to grow the bacteria and test it in a laboratory. So it's believed they're not resistant based on limited research studies, but resistance testing is not widely available. On the other side of the coin, we use doxycycline for 6 months, 12 months for treatment of acne. So the last thing in anybody's mind is antibiotic resistance. My concern is chronic disability from a partially or untreated infection. So the issue of antibiotic resistance applies. I'm an infectious disease doctor. I work in the hospital. I see all sorts of resistance, and I get people off antibiotics at the hospital for gram-negative sepsis within 7 to 14 days if possible, because we understand antibiotic resistance with Klebsiella and multiple resistant gram-negative organisms. But with doxycycline and Lyme, my concern is cure of infection, not antibiotic resistance.
Perfect. Thank you.
Thank you. We have another question coming.
Hi, my name's Brian Raid. I'm a naturopathic doctor. We run the German ELISpot test in our practice all the time, and your in-house study looking at the ELISpot compared to the ELISA test is really, really interesting. And I was just wondering if that's been published somewhere or if that's just in-house data at this point.
I think it's in the public domain. It was actually presented as an abstract to the ILADS conference in 2017 in Boston. So it is available in an abstract form. It was never published beyond that. The challenge, however, is people say everybody has a positive ELISpot. The reality is that not everybody has a positive ELISpot. I have lots of patients who have negative ELISpots. The ELISpot test is probably oversensitive, so it needs to be interpreted in combination with the patient. But it picks up many patients who have low-level infection where the antibody test does not pick it up, is my understanding of the assay.
Great, thank you. And just to add, we get negative ELISpots all the time as well, so I also see that. Thanks.
Good morning, Doctor. Mark Hewitt, physicist. I spent 7 years with Dr. Bill Curry in the immunotherapy development. We had found that a number of our patients were coming in, and we found secondary infectious issues related to Lyme disease. So we had a breakout study for about 3 years before we lost Bill. And almost everything that you've put up on the slide today, we can collaborate. One of the things that we found was the difficulty in determining the protocols for proper secondary infection tests. Do you have a series of recommendations that a physician can use today to help diagnose especially the viral infections that are typically secondary?
Well, no, it's absolutely a challenge. There's a new test that's been released in the European Union called TickPlex Plus, which was developed through the University of Finland through a European Union grant. And the TickPlex Plus picks up lots of different strains of Borrelia, some of the persister forms of it, and many of the co-infections and viruses. So I tend to use that test preferentially rather than patients picking one test versus another test. I find virus tests not too helpful because if you have a positive tick-borne infection test, because virus tests are often positive. If you have a positive Epstein-Barr antibody test, 50% of the world has positive Epstein-Barr antibody tests. It's so common. You have to then determine, is that Epstein-Barr virus causing the patient's symptomatology? So that really is the challenge. So there's lots of co-infections. Until we have PCR tests or can culture these bacteria and viruses in the blood, until we have better tests, we actually have to use clinical decision making and make clinical judgments. And all of the diagnostic testing, positive or negative, can be supporting, but they don't rule out many of these active infections.
Thank you. We have another hand up right there in the center.
Hi, my name's Dr. Cecilia Newton. I'm a family doctor in Lunenburg. And so you are advocating for clinical diagnosis of Lyme and sometimes treating patients for prolonged courses of antibiotics, maybe weeks to months or years. So presumably that's based on informed discussions with your patients. And I'm just wondering how you counsel your patients on the possible risks of that kind of approach.
Okay, well, first off, I don't treat people for years and years. This is one of the kind of myths that I think goes on. However, I'm an infectious disease specialist. If you catch an infection early, you can treat quickly with a short course of treatment. But what if you don't catch that infection till 6 to 12 months? So Q fever, Coxiella burnetii, as an example, you catch it within a month, 3 weeks of doxycycline, Bob's your uncle, you're cured. If you wait for 6 to 12 months, you have to treat for 18 months with doxycycline, rifampicin, other antibiotics, hydroxychloroquine, because it's already disseminated. So the belief of many and the science that I think ILADS uses is that disseminated disease is much more complicated than early disease. And yes, if you get people better on doxycycline after 3 weeks and you stop and they get worse again, you treat longer. How long is long? I think you have to use your clinical judgment. And you do tell patients that the standard guidelines say 3 weeks, but 3 weeks doesn't always work. And the guidelines are changing all the time. But the changing guidelines are not based on good science. They're just based on opinion. The NICE guidelines all of a sudden have said 6 weeks rather than 3 weeks. IV ceftriaxone, 2 grams twice a day for a month if you suspect neuro. This is not kind of evidence-based. It's just an opinion that people have come up with. So we actually do need better science in this. But I think you do have a discussion with patients that the guidelines say 3 weeks. I treat people for osteomyelitis. The guidelines say 6 weeks. If you look in Ireland at the outpatient treatment of osteomyelitis and outpatient antibiotics, some infectious disease specialists are treating for 6 months. The guidelines say 6 weeks. Is it wrong to treat 6 months? No, it really should be symptom and clinical assessment and response to treatment. So osteomyelitis, in my opinion, is no different from persistent infection from borreliosis and other infections, but it is a challenge. For any other infectious disease, I can treat tuberculosis for 6 to 18 to 24 months, but if I treat for more than 4 weeks of doxycycline, all of a sudden you're viewed as a criminal. Antibiotic resistance, which is not really a big issue. One of my colleagues in France basically says rheumatologists treat Lyme arthritis for 12 months with doxycycline, and they're miracle workers. Infectious disease doctors treat Lyme arthritis for 2 months with doxycycline, and they're charlatans. So figure that one out.
Thank you. We have time for one more question, perhaps. If there is, are there any hands? I see someone in the middle there.
Hello, my name is Emily Black, and I'm a veterinarian. I just wanted to speak with respect to the doxycycline resistance. In veterinary medicine, we've been treating Lyme for decades with doxycycline, and the way we go about it is we test And then if they're positive, we treat for 6 to 8 weeks, and then we retest to ensure they're negative. Now, these dogs that are coming back in, if you're predisposed to getting a tick bite with Lyme, you're predisposed to getting it again and again and again. And we are treating these dogs repeatedly, and we're not seeing any antibiotic resistance on that front. We're talking years here. We're talking every dog that comes into the practice is getting tested annually. So I don't know if that helps alleviate some fears, but it's what we've seen in practice.
And I think the infections, thank you for that comment. The infections that we're not talking just about Lyme here. There's lots of co-infections. There's crypto infections that, for example, chlamydia pneumonia, chlamydia trachomatis, sexually transmitted chlamydia. If chlamydia disseminates to your joints, it's called Reiter's syndrome. It causes an arthritis. If you treat for 2 months of doxycycline, it comes back again. If you treat for 6 months with doxycycline and rifampicin, it goes away and you're cured. So there are research studies to show that some of these intracellular infections need longer course and even combination course. And the studies have showed that you do not develop resistance to these antibiotics, but you do develop persistent disease if you don't treat these infections, whether it's Lyme, chlamydia, pneumonia, Bartonella, and other infections that are probably more common than we're aware of. Why are we not aware? We're not aware because we're too much caught in denial mode. The vets are way ahead in terms of their diagnosis and treatment of these vector-borne infections than human doctors are, and it doesn't look like it's going to change anytime soon with the current kind of debate between ILADS and IDSA, unfortunately.
Dr. Lambert, we have, I see the mic has been passed, so we are going to fit in. There's no such thing as a quick question here, but we'll try and squeeze in one more question, please.
Thank you. Hi. My name's Heather Robertson. I'm a hospitalist at Social Regional. We know that we know that we're in an endemic area, and many people occupationally and recreationally get repeated exposure. Would you support patients having access to repeated short courses of doxycycline, maybe having a prescription at home so that when they identify a tick, they can just start without physician intervention?
Well, you see, you have to kind of know what your ticks are carrying. If the ticks in a certain county have 0 Borrelia, does it make sense to put people on prophylaxis automatically? Probably not. If you're in Old Lyme, Connecticut, where 70% of the ticks are positive for Borrelia, yes, I'd probably do that. But it's no different than I treated somebody yesterday for HIV post-exposure prophylaxis. You know, how much HIV is in the heterosexual community down in Southern Ireland? It's probably 0.001%, and the chances of catching HIV from unprotected sex is 1 in 10,000. Would I put people on HIV PrEP? We put them on HIV PrEP all the time, a month of Truvada, probably unnecessarily. However, if you're in KwaZulu-Natal, South Africa, 70% of the girls are HIV positive. Would I take HIV PrEP following that exposure automatically? Yes, I would. So I think you have to, it's not as simple. I think you should have a low threshold for treating with doxycycline in Lyme endemic areas, even before patients get symptomatic. The alternative is as soon as they get symptomatic with any kind of illness, flu-like illness, arthritis, just feeling badly following a tick bite, I think at that stage I would definitely add the doxycycline. So no easy answers.
Thank you so much, Dr. Lambert. A round of applause, please, this morning.